All right. Well, thank you to everyone that is trickling in to the last event of the day today. This is the first event where we have a live moderator. So welcome, welcome, welcome. I'm Lisa Bilek. So I have been a board member with Defeat MSA for a little bit over 1 year now. So if you were on the conference last year, you get to see me again. I have been working with Defeat MSA after losing my dad to MSA about nearly 9 years ago. I've been really interested in staying involved with the community. Professionally, I do have a doctorate in neuroscience and a little bit of a research background in Parkinson's disease. I don't work in Parkinson's anymore, and today I'm just here to make sure that your questions get answered. And without further ado, let's get started with the three individuals that we're all here to chat with and learn from today. As we get started, do keep in mind that any questions that you put in the chat, it's going to be monitored by myself and by our administrators. So feel free to interact with our panelists there. We have also been collecting questions that appeared in the chat through the other presentations today. So I'll do my best to make sure that those are prioritized and get answered today. We did have a little bit of a technical glitch. So if I'm looking at a weird area of the screen, that's just because I needed to adjust my setup. So I do apologize for that. However, without further ado, let's go around and just introduce the experts and clinicians that we have with us today. Let's start with Dr. Edwin George.
Hello, everybody. I'm glad to be here today. I am a movement disorders neurologist in Michigan. I was on the faculty of Wayne State Medical School for many, many years. And now I'm semi-retired, but I work for the FDA reviewing new movement disorders drugs. So that keeps me busy. And because I work for the government, I do still see patients, but at the local VA hospital.
Wonderful. Thank you so much. And thanks for being here. Next, Dr. Enrique Urrea-Mendoza.
Well, thank you so much for having me today. Good afternoon, everyone. Yes, as Lisa mentioned, my name is Enrique Urrea. I'm from Colombia originally. I speak Spanish as my first language. So if you have any question in Spanish, happy to answer it as well. I'm a movement disorder specialist working in Tallahassee, Florida. I'm the director of the movement disorder clinic in Tallahassee. The hospital is called TMH, Tallahassee Memorial Healthcare. And at the same time, I'm a professor at the medical school in Florida State University, FSU.
Thank you so much. And finally, last but certainly not least, Dr. Oybek.
Hi, everyone. My name is Oybek, so you can call me and refer to me as Dr. Teo. So I have my quite complicated surname. So I'm a neurologist specialist in movement disorder and currently practicing in Moscow. And part-timely, I'm based in Tashkent, Uzbekistan. So my main interest is Parkinson's disease, but I have quite a huge number of MSA patients. So I'm currently providing care for them for the last 8 years. I also teach and give lectures for a younger neurologist here in Moscow, and also try to build community in Uzbekistan. As you know, there is quite a struggle for movement disorder specialists there. So it's nice to be here.
Wonderful. Thank you so much. And I'm seeing quite a few thanks and hellos from the chat. So we really have a group that's excited to chat with you today and grateful for your time. So let's get started and make the most of the next hour. We started out this morning learning about diagnosis. I certainly recall my dad's experience with getting the diagnosis of MSA. He lived with what we thought was Parkinson's for a couple of years before finally being diagnosed with MSA. And we learned that it can be very tricky to not only diagnose this disease, but also differentiate it from Parkinson's disease. Can we maybe start with some comments on maybe how you think about differentiating what may clue you into this being MSA as opposed to another condition. And to start us out, maybe Dr. Teo, if you want to get us going on this.
Yeah, thank you very much for the question. It's quite a complicated issue. I mean, in differentiating Parkinson's disease and MSA, especially in the early disease process, if you're taking, for instance, first year or two, basically because they might look quite similar in terms of movement symptoms, and their autonomic dysfunction can be subtle. And so we may have some issues in terms of identifying them. And per studies, if you look to the studies, we can see that there are some categories of MSA patients, like a late onset MSA patients, or let's say long living MSA patients. I have some patients whom I changed diagnosis from PD to MSA after 8 years of successfully being treated like Parkinson's. I'm not quite sure what's the mechanism behind this separation in terms of the phenotype of the disease, but it can be difficult, I mean, early on. But the other issue is also that if for instance, colleagues or not movement neurologists or other doctors who also provide care for patients, they don't specifically look into these red flags of MSA, they might miss early onset MSA in patients. Also, we need to highlight the red flags and supporting features that we can find in MRI, for instance. In my clinic, we basically do MRI, or especially in young onset PD patients, for instance, with the disease onset before 60. And we're specifically looking for the volume of putamen, cerebellum, pons, in order to rule out or rule in the possibility of starting MSA, because sometimes we can see that patient didn't manifest with the autonomic features, but we do see some subtle hypertrophy in a contralateral putamen, or some subtle hypertrophy of pons. So making us more suspicious in MSA, and taking quite deeper look to the patient and asking him to come for more frequent follow-ups. Also, we need to be quite suspicious when we see that the medications that we use are not providing satisfying response. For instance, you're prescribing levodopa, but patient's not responding well, and you keep increasing levodopa, and start having this autonomic. You might consider this as a side effect of levodopa, but this can be the early onset of autonomic dysfunction. Sometimes it is also difficult to establish MSA because patients may come to you early on with the disease, complaining of dizziness, and you start looking for some subtle signs of ataxia, didn't see that much, and you might falsely label them as a psychogenic dizzy patient, especially if patients also telling you about some stress history and so on. And if you don't follow them up, you might miss early signs of MSA too. It can be tricky in the first 3 to 5 years of disease onset.
Yeah, I'd like to add to that. We often, in movement disorders, focus on patients who present with Parkinsonism and whether they have one of the Parkinsonian diseases, and it may turn out to be MSA. Of course, we also see patients who present with cerebellar symptoms originally, and there's a pretty broad differential diagnosis there. There's more than 50 spinocerebellar diseases, as well as cerebellar stuff can be a symptom along with a variety of other diseases. So you end up with very broad differential diagnoses. And then some people start with autonomic symptoms, and they often end up with a cardiologist or a urologist who's trying to figure out what's going on. So all of this can make for quite a while to sort it out. And as the disease progresses, it becomes more clear. The bad news is we still don't have a cure for MSA, though we may be getting close. The good news is we have a lot of treatments, and the treatments are to treat the symptoms you've got. So if the diagnosis hasn't been pinned down, but you're seeing a specialist in autonomic problems or a specialist in Parkinsonian problems or a specialist in cerebellar problems, we can give you the appropriate treatment, even if we are not calling the disease by its real name until it gets more advanced.
And I want to add as well, Lisa, if it's okay, Dr. Tu and Dr. George, they has covered the challenge that we have in our daily clinic. Many patients just the first question that they have at the beginning of the visit is why doctors take so long to make the diagnosis. That's the first question. And you already mentioned, like, for instance, the personal experience by Dr. Tu, that he changed the diagnosis after 5 to 6 years. So I believe that movement disorders is the most humble, I would say, career in the medical field, because we need to revisit our diagnosis every day, every visit, and accept that we make errors. And speaking about errors, according with some papers, even in the best center of the world, in movement disorders, best center, we cannot diagnose MSA or Parkinson's disease with a 100% of certainty. And the percentage of making errors is almost 20%, 15 to 20%, even in the best center, right? So we need to be clear in that. And my last comment is regarding the functional mood disorders. Oh, yes, this is very important, because sometimes we label the patients with functional mood disorders, and don't forget that even 30% of the patients with functional mood disorders will end up being a Parkinson's disease in the future, right? According to some papers. So don't forget that part.
That's an incredibly challenging picture and set of symptoms to sort out, especially since many patients will present so differently with the disease. That's a lot. Thank you for all you're doing. This morning we did have a question specifically about MIBG, myocardial scintigraphy. Can you comment on that particular test and what kind of information, if offered to the patient or appropriate for the patient, what kind of information might that provide at the time of diagnosis?
Who wants to start?
Well, I could start. It's a type of imaging that tells you about the nervous system connections to the heart to regulate the blood pressure and so forth. And it actually mostly can rule in Parkinson's disease versus the other Parkinsonian movement disorders, because the effects on the nervous connections to the heart are lost much more prominently and early on. The dysregulation of the blood pressure and so forth that happens in other diseases, particularly MSA, happens at a different level of the nervous system. So it can be very useful in trying to pull apart the differential diagnosis.
Thank you so much.
I just want to add to that comment that yes, so this is a tool that we have some research about that tool, but we don't use that quite often in clinic. That's true. I don't know if Dr. Tu has experience.
Unfortunately not available in the place where I work. We have also issues with using that scan, actually, also quite, difficult to obtain it too. Yeah, so mainly clinic and MRI.
But some of these things are used primarily when you're doing research on treatments. Treatments for MSA may be different from treatments for Parkinson's, and other diseases. And these are all diseases that are neurodegenerative diseases that progress. So you want to use the treatment as early as possible, but you want to use it in patients who have the disease that you want to treat. So it's easy in the clinic in a way because we treat the symptoms and we can change the name of what your diagnosis is. It's no big deal. But if you're going to enroll in a study that's going to go for a year or two, we really want to be sure we're studying what we think we are. So there are some very sophisticated tests that can be used in research to try and really hone the diagnosis early. But for the most part, it's just not worth using those in the clinic. And they're not readily available unless you're really doing research.
Mm-hmm.
It is really cool to see that overlap and how the field of MSA really goes from the research world to something that's being available to patients. And oftentimes it's tempting to see these new advances and really wonder what it can do for you, but proper testing is certainly needed before those things are a reality. I think one area that we're getting a lot of questions about in the chat as well is the role of biomarkers. So I think this is an area where we've really seen quite a bit of research. Of course, Dr. George, you spoke on this earlier today about how biomarkers help us understand MSA's progression and perhaps even diagnosis. Dr. George, do you mind commenting on perhaps the role of biomarkers and specifically on the alpha-syn biomarkers for MSA?
Yeah, well, biomarkers actually, as I tried to point out in the talk, have a number of different uses in different situations. So we have diagnostic biomarkers that are part of the diagnostic criteria in some cases to try and help us make the diagnosis in the clinic, and also used very much for trying to enroll the appropriate population of patients into research studies for whatever's being tested. But we also have biomarkers that can be predictive biomarkers. They tell us whether you're likely to respond to a particular treatment or you're likely to have an adverse effect from a particular treatment. We have prognostic biomarkers, and there's a slide in the talk where we talk about actually looking at neurofilament light, which is a favorite biomarker in these neurodegenerative diseases because it really reflects the breakdown of nerve tissue in any neurodegenerative diseases. So it turns out it's not so useful for diagnosis, although it can be part of a group of biomarkers to help. But patients with higher levels of neurofilament light in their circulation have been shown to progress more rapidly than patients with lower levels. And again, that can be helpful in research because you want to have patients that you expect to progress within the period of the study so you can see if your treatment is having any effect. Again, they're not used much, that's not used all that much for MSA in the clinic, although it is used for some other diseases where the levels change over time. MSA, they seem to stay about the same. But you mentioned alpha-synuclein, and alpha-synuclein is a little tricky. It can really help with diagnosis if you're able to distinguish the different folding patterns. Everybody's got misfolded alpha-synuclein, but it's different if it's Parkinson's or if it's dementia with Lewy bodies, which is another common Parkinsonian disease, or if it's MSA. And so there are ways to use that to try and pull things apart. I mentioned in the talk also the skin biopsies. And skin biopsies are generally done in these diseases to look for the presence of the misfolded alpha-synuclein in the skin and tell you that, well, you're definitely dealing with one of these diseases that we call synucleinopathies because they involve misfolded alpha-synuclein. But it also turns out that the pattern of where the alpha-synuclein ends up in the skin and whether it likes to be around blood vessels and so forth. It gives you some clues as to whether you might be dealing with multiple system atrophy or Parkinson's disease. Though, again, these are not necessarily prime time uses for the differential diagnosis, but we grab onto every hint we can come up with to try and hone things down. So biomarkers are very useful, and as I tried to explain at the end of the talk, we can actually use them to probe what treatments are doing and what's actually going on in human beings, because we do a lot of drug research on animals, but an animal model of a human disease is not necessarily the same as the human disease. So being able to look at biomarkers and see what's changing and get a feel for what aspects of the disease are playing a role at a given point is really extremely useful. So lots of uses for biomarkers.
Awesome. Thank you so much for that. All right, let's move on from diagnosis to what a patient may be experiencing in that period of time once they know they have MSA and their care plan has started. So Dr. Urrea-Mendoza, can you comment on, what your plan may be for a newly diagnosed MSA patient, maybe the role of common therapies such as levodopa, where these therapies are likely to help, and maybe even, some of the common side effects that you may see once treatment is initiated or continued?
Well, I think that in order to organize a good plan for any patient with Parkinsonism in general, is that the exercise, two different therapies, medications and other non-medication that maybe we can use, non-medication therapies that we can use. The first thing is exercise, changes a little lifestyle, right? And as soon we can start doing a regimen with exercise, that is very good. Even if the patient has a little more problems. Well, as we saw in the lecture this morning, Tai Chi can help even doing the exercise in the patient using a chair. So that's the first thing. So we have a multidisciplinary team. As soon as the patient is diagnosed with MSA here in my office, so we have other members of the team, so that is going to see the patient, evaluate the patient. Physical therapy is very important, speech therapies, occupational therapy, social workers, neuropsychologists, psychiatrists, and dietitian. We have all the team here, and I believe that I would say my teaching point with this discussion is the patient needs to be seen by a multidisciplinary team in order to have a good plan of treatment. And regarding the medication, yes, carbidopa, levodopa is, I would say, a test and at the same time a good treatment for Parkinson. Dr. Chu already said that many patients at the beginning, obviously, they look like Parkinson disease, and a strong response with the medication is a good indicator that the patient has a Parkinson disease, correct? However, we need to keep in mind that at the beginning, almost 60% of the patients with MSA can respond in somehow to carbidopa, levodopa. Okay, and it has been proven in pathology. Patient that responds with very good at the beginning with carbidopa, levodopa, they have a positive, I would say, autopsy for MSA, or a positive proof that the patient had MSA. The problem is with those patients that maybe don't have a good response or start having or losing response over the time. That is the problem. So we never stop the dopamine because we know that somehow the medication is helping. That's one point. The second point is, in order to prove that dopamine is not working, so we need to put the patient at least with 900, according with one school, or 1,200 milligrams of carbidopa, levodopa, at least for 3 months. And if we don't see any response, at that point we say, well, the patient is not getting any response. And one more time, we never stop, we never decrease. Maybe we decrease if the patient is having a very bad or very severe orthostatic hypotension. That's another problem in MSA. And I remember what a couple of patients that they called me, well, why you are increasing the carbidopa levodopa when one of the symptoms is orthostatic hypotension. The insert says that it can increase the orthostatic hypotension, blah blah blah. So after a big discussion, well, maybe we understand that the medication, the dopamine, is necessary as part of the treatment. Sometimes we need to decrease depending on the response of orthostatic hypotension, but we never stop. And the other thing that is very important is that the carbidopa, the levodopa, can cause, I would say, an interesting side effects in MSA because it can cause early dystonia and mainly a facial dystonia, right? It's not, or dyskinesias and dystonia, not just like dystonias or dyskinesias that we see, dyskinesias that we see in Parkinson, just facial. That's, I will say, like another test to see, oh, this is an MSA, is not a Parkinson disease. That's my comment about carbidopa levodopa, the Cinemed. I don't know if Dr. George or Dr. Tu had a different idea.
Well,
Yeah,
go ahead.
Thank you very much. I'm sorry, it's a bit of lag, so I'm sorry. Yeah, then I will just finish. So yes, I totally agree. So we usually do see sometimes, especially in early onset, in young onset patients with MSA, let me say like this, sometimes while increasing the dose of levodopa, I usually do see patients with oromandibular dystonia and appendicular dyskinesia or dystonia. But in my point of view, I just mark this as a good sign because levodopa is working and they are having these dyskinesias. To my opinion, to my opinion, I don't know whether do you agree with me or not. In my point of view, this means that we need to continue levodopa because they are having some benefit from it. Usually, the dyskinesias are not that bad and they are not experiencing severe fluctuations. But overall, of course, the response is not that, say, satisfactory in the doctoral point of view, because if comparing, for instance, to patients with Parkinson's disease. But coming to care plan, of course, I mean, the levodopa is not the only thing that we can provide, because there are so many issues coming from urinary, bladder, orthostatic, postural problems. For instance, in my clinic, we do quite a huge number of patients. We do inject them botulinum toxin for camptocormia and other postural deformities. If done early on, when the postural deformities are only forming, we do have quite a good, fascinating responses when, for instance, patient is coming with span bend is for 30 degrees, and then you inject them in their abdominal muscles, and patient is now walking again straight. That's good. But if it is long term camptocormia, botulinum toxin doesn't help that much, actually, especially because the degenerative spine is also coming up, and sometimes you also see the osteoporosis and so on. The same goes for the urinary and bladder problems, because we do usually refer them to neurologists, GI specialists, so they can help us with managing this, the retention things, or in the beginning of the disease they may have hesitancy without retention. So sometimes basic drugs can help, but later on, of course, I mean, when retention comes, we usually refer to neurologists to manage them. Yeah.
As far as the levodopa response, we do have a question in the chat about some symptoms that may actually get worse following kind of taking that medicine. Are you familiar with speech or posture problems getting worse following initiation of that therapy? Or perhaps there may be some other question that we should be asking?
Well, I have several cases where after injection of levodopa for the first, for instance, 30 to 45 minutes, patients do refer of worsening. Some patients telling that the posture, gait, tremor gets worse. I think this phenomenon actually depicted in literature. So we do see this kind of fluctuations in PD patients too. In some cases, this can be due to the the orthostatic drop blood. A blood pressure drop, and some patients may refer these movement issues like speech and dizziness and brain fog and postural issues to levodopa, but the mechanism may be linked to the drop of blood pressure, especially in the morning after the first dose, the very first dose in the morning. Yeah.
I do recall my dad, he was a college professor, so he would keep a log of, when he would take his medicine, when his symptoms would get worse, and when other symptoms would get better. And he found this optimal window of taking his levodopa 45 minutes exactly before he needed to give a lecture, so that his speech and dystonia, things were kind of minimized, but he still got the maximum efficacy, benefits that he could hope for from that medicine as well. So kind of understanding how your own body and symptoms are responding, I think can be really helpful as well, kind of knowing that some of these things may occur along with dosing. You mentioned orthostatic hypotension. Any thoughts on how this may be handled, or maybe what are some of the symptoms? Does this get worse over time? Dr. Urrea-Mendoza, do you mind commenting on orthostatic hypotension?
So before to answer your question, Lisa, yes, let me add something about the carbidopa levodopa, because that is a very common call from the patient. Hey, I started medication and I developed more tremors and I developed insomnia. Honestly, the cases that I recall at this point, that the start of the medication is almost at the same time with something else in my clinical experience, and they have worsening of symptoms because they developed at that point infections, UTIs, or pneumonia. So it's not the medication that is causing the worsening of the symptoms, right? It's something else. And I explained the same thing with the patients. If they are okay today and tomorrow they are hallucinating, they have a lot of hallucinations, agitations, that is not the medication. It's not the levodopa. It's something else. Normally infections. The other thing is, although the report says that it's very rare, it doesn't happen. My school, they already told me, no, that's rare. I had 2 patients with allergy. They developed severe allergy to carbidopa, levodopa, and I had to stop the medication. And believe me, they developed allergy. I saw the reaction. So that is very rare. Oh my goodness, it's very rare. But it happens because the pill, and Dr. George will correct me if I'm wrong, the pill has colors, right? And obviously that can cause allergy. It's not the carbidopa levodopa, it's the pill, right? The pill. I don't know, Dr. George, you have a comment about it?
Yeah, there's a lot of things that go into pills besides the actual drug. And if you see a reaction, because levodopa plays such a central role in treating these diseases, it's worth trying different carbidopa levodopa preparations, because it's unlikely
Sorry
that
about that. I have something here. I don't know how to go.
it's unlikely that the patients are actually allergic to the levodopa itself. And so by using different pills, you can often find one that they won't have an allergic response to. And particularly the dyes for coloration are often the culprits, but it can also be some of the other fillers and so forth that go into the tablets.
Can I add on this issue? I have 2 patients two patients. Both of them are Parkinson's patients. They have developed the itching on, in response to levodopa preparations, either levodopa benzerazide or levodopa carbidopa or levodopa carbidopa and entacapone. And I end up with, I tried every possible preparation that I have, and I just end up with, this mucuna drug, that, Ayurvedic medication.
Clonoperians.
Yeah, that was the only thing that she can, take and have some benefit, except from, the dopamine agonist. In addition to them, levodopa, she can withstand it because of, severe itching. Yeah, that was, I saw this two patients with this issue.
The other thing you can try is the dopamine agonists, but obviously they have their own adverse effects. So.
And the problem with the mucuna is that that is a supplement, right? It's a natural supplement. And according with some research, well, you cannot predict the amount of dopamine that the brain is getting. You cannot do a titration. And even if the patient doesn't have a good response, well, you don't know if the medication is helping or not, because we don't know exactly how much dopamine your brain is getting. So, or the brain is getting. So that's a little tricky with that the mucuna. But sometimes we need to use it. Yes, I remember one patient, 92 years old, I think 90, a little more, Parkinson disease, no MSA, Parkinson, and she is doing pretty well with mucuna, and she prefers to take the mucuna, not the medication.
Yeah, generally we recommend that people stay away from that because it complicates titrating the drugs. And one of the things I wanted to mention earlier is that it should be pretty clear from all the different things that have been said. For these diseases, you really have to have personalized medication regimens for individual patients and where they are in the progression of their disease. So it's really crucial to do that to get the good benefit. And it's hard to do that if they're taking something like mucuna, where it's not just how much is in this batch, but how much is in the next batch.
Right.
You just can't sort things out very well. But if none of the things that are better controlled in terms of their dosage work, then you may end up having to use that. So we should go back to the orthostatic hypotension.
Yes, go back to the question. Well, in order to answer that question, well, again, we have pharmacological treatments and non-pharmacological treatments. The first thing that we need to do is to confirm that the patient has an orthostatic hypotension, and to confirm what could be the cause of that, right? Let's say some Parkinson's disease, they have a little orthostatic hypotension, but they are taking too much anti-high blood pressure medications, right? So the first thing is just to stop or decrease that medication that can cause orthostatic hypotension. To confirm the diagnosis, well, normally we do a TIL test, or we just check the blood pressure in the clinic. So asking the patient lie down, I do for 10 minutes, then asking standing up for 3 minutes. There are different reports about taking after 1 minute, 3 minutes, and 10 minutes, depending on how fast the clinical development of symptoms. But normally in clinic, we do after 3 minutes. If the high number, which is the systolic, drops more than 20 points, and the lower more than 10, normally we do the diagnosis in clinic about the orthostatic hypotension. Now, at that point, again, check the medications. If the patient is symptomatic, because we care about symptoms, we don't care too much about numbers, right? If the patient is symptomatic, we have options. We start medications like Myodorine, Florinate, Droxidopa, which is a medication that was approved recently for Parkinson's disease, honestly, and pyridostigmine. Sometimes we use, depending on, we maximize, or at least in my clinic, we maximize one medication, and if it's still not responding, we add other medication, or really checking for side effects, because unfortunately that medication can cause side effects. That's another topic to discuss. But the most important as well is the non-pharmacological measures. So increasing the intake of water, or eating a small portion of food, a small breakfast, lunch, and dinner, and the patient can snack in between. That improve the the postprandial orthostatic hypotension. Using compression socks or abdominal binders, even eating salt, right? But it depends of each patient. It depends of each case. It's not that easy. Sometimes it takes months, 3, 4, 6 months, just to get a specific treatment, personalized treatment for each patient. Unfortunately, we don't have any rule, any guidelines to treat each one with in the same way. It depends a little of the experience and at the same time of the patient's symptoms. I don't know, Dr. Q, you have or Dr. George.
So one other thing, the non-pharmacologic treatment that I often find helpful, if people can sleep lying flat, but with their head 4 or 5 inches above their feet. Bent in the middle with a hospital bed doesn't work. You've got to be lying flat and the whole thing tilted, usually by putting some sort of support under the head of the bed. But it really keeps the reflexes that tighten up the blood vessels active through the night. And so you have particularly less problems with orthostatic hypotension first thing in the morning.
I would also wanted to make some notes on the problem that is opposite to orthostatic hypotension, that's the supine hypertension. Sometimes we try to, when we are over managing the orthostatic hypotension, we can end up with having supine hypertension, increasing the blood pressure when patient is laying down. So, and sometimes I, for instance, in my clinic, I have several cases where patient is not having any signs of orthostatic hypotension symptoms, but is suffering from severe headaches overnight. And when we do the monitoring of blood pressure, we do see that overnight patient is having very high BP. And we also have the medications for them. And as Dr. George highlighted, that's the positioning of a patient. But I do generally recommend to make the head part of a bed a bit higher, to put some bricks under the head part of a bed, so the whole bed is a bit on the angle. For some cases, I would say, in my experience, in like over half of my cases, this would work. For others, we do use some blood lowering medications for overnight, short term, so just to lessen the symptoms.
Yeah.
Thanks for mentioning all of that, and I'm just continually struck by how creative all of you are in ensuring that all of the symptoms, all of the side effects, all of the communication between you and your patients is really informing how that care plan gets put together, and how it may change over time. And this theme that we keep bringing up amongst us is that idea of really the need for a personalized treatment plan, which really can only be developed by the person living with MSA, perhaps their care partner, and the treating clinician. So I want to make sure that as we're talking through some of these more common symptoms and some really amazing and helpful ways to treat them, we get back to that idea that finding the right thing for each individual patient really needs to come from that conversation that each of the people living with MSA are really having with their treating neurologist. So can we maybe just make a little checklist of maybe some of the ideas that each of you may have to ensure that, when the patient is seeing their neurologist, that time is best used? Would you recommend a checklist? Would you recommend, tallying up when symptoms are occurring? What kind of information and how you receive it is really most helpful in identifying, the next best step for that individual? Can we start with Dr. George? Do you have any comments on that for our audience?
Well, certainly the patient and caregiver, if they are noticing anything, they should write it down and bring it so that they'll remember to bring it up during a patient visit, which unfortunately are often all too short to really communicate everything you'd like to hear. We have checklists of things that we try and ask about to see if you're having certain types of symptoms. But only you know what you're experiencing, and bringing it to our attention is extremely helpful. You know, what's bothering you is what you should write down rather than necessarily following a checklist. Though there are some symptom checklists out there you could get and use.
Dr. Urrea-Mendoza, any thoughts on, what's most helpful in communicating from a patient and caregiver to you when you're in that infrequent office visit?
Well, being honest with you guys, I have another issue with the alarm here. So, and the sound it broke down, so I couldn't hear the full question. So I don't know if you can summarize the full question. I can answer. Lisa.
Absolutely. We're talking through, or we have been talking through some of the more common symptoms that individuals may be experiencing, some of the things they've noticed after taking their prescribed medication for their MSA. And rather than, leaving this as an overwhelming list of potential ideas that are so creatively summarized by all of you, if we could just give the MSA patients and their caregivers maybe some strategies to kind of manage your own disease and really empower them to bring these to you in a way that really gets to the best care plan. So if you kind of think about an MSA patient and their caregiver coming into an appointment, what leads to the best appointment? Is it a list of symptoms? Is it what's kind of most useful in developing that care plan that a patient can do? Okay.
Thank you so much. Well, I think that the best thing to do is, and I asked my patients as well, is bring the family, bring everyone interested in taking care of the patient, right? Because as much as we know, as much as we discuss about the disease, the symptoms, the medication, that will be helpful for everyone. And as a doctors, we become a part of the family as well, right? Which is very, very, very good. So, and there are many different discussions and many things important during each visit. Each visit is completely different, honestly, because it depends on the most challenging symptoms, and sometimes it's not necessarily different symptoms. It's just they want to talk. That's very important. Not just the patient, the family, right? The family members. As Dr. George mentioned it, well, yes, a list of the most common problems at home is very helpful to discuss during the clinic, right? Because again, each patient is completely different, and each patient can have different symptoms. Like the most bothersome symptom to me today, let's say constipation, right? So okay, let's focus on constipation. No, the most problem symptom to me is the insomnia or the orthostatic hypotension plus the supine hypertension. Okay, let's talk about that. Okay, it depends on each patient. Okay, but don't forget something as well important is sometimes in clinic you need, as a doctor, you need to start the conversation a little more than that. Excuse me, conversation about what is going to be the future. Finances, wills, okay, discussion about what is going to happen if the patient dies. What is the wishes, or what are the wishes? Okay, so that's another conversation that many sometimes we don't take in clinic in many visits, but as a movement disorder specialist, we need to do that. I don't know, Dr. Tu, any other ideas?
The last issue that you've highlighted is quite complicated in a region where I do practice because of cultural differences, and say most of times people are actually not prepared for discussing such an issues of end of life care actually. And I don't have that much cases where I was successful, in discussing these issues. So coming back to the checklist and the way how to, improve the, efficiency of a meetings, I I try to, prolong meeting in terms of, I see a patient and I use the time when I meet with the person just to, to check his condition, to do an examination. And I have some my assistants that are, actively in on phone calls, because patient's condition can change rapidly. And for instance, I'm not sure that, each 3 months of follow-up, each 2 months of follow-up can be enough to pick these changes. So my assistants call each, they make phone calls for up to, 30 to 40 patients every day, just to say hello and ask for their condition. Is they okay? Do they have questions? And if, for instance, if they have questions and I have time, may give some, short response on phone call, or, we basically do a regular email chat. So, I mean, if they have some questions, urgent questions, so I respond to them in the email. And other issues that are more, pro-gradient, we can discuss in a regular visits. But I found that in MSA patients, so these, online condition, when they are always with them in connection, is more efficient than some follow-ups for like each 2 to 3 months. It can be, it cannot be effective as much as we wanted, because as I say, for instance, if some subtle, if there's some subtle issue is going on, like, pneumonia, the patient got sick, like, let's say, we remember the era of COVID. Yes, so they have some fever, so we know we are prepared that they can, dramatically worsen now. So we are increasing medications. We're trying to make as much as prophylaxis as we can, prescribing them, the physical activity, the respiration exercises, some drugs. In terms of, for instance, if they got hospitalized, I always, try to be in touch with, admitting doctors, because the MSA cases are rare, and not every hospitalist is familiar with the condition and the possible complications that may come. Yes.
Thank you so much for that. And I see we only have about 7 minutes left, but I see a question in the chat that I think would be really wonderful to for us all to comment on and maybe wrap up on. So Candace is asking, can you share the area of research that gives you the greatest bit of hope that MSA might one day be better understood and treated? So what makes you most hopeful, and what are you most excited about? Dr. George, let's start with you.
Well, I mean, all of the research that's aimed at MSA is very exciting. And I will say, I've been in this business a long time, and there was a time when you could count the number of studies that had been done to try and figure out treatment for MSA patients on both your ears, and that was it. And there are so many studies being done more and more every year. And there's a lot of different areas that have potential for a breakthrough. And you never know. That's why it's a breakthrough when it happens, because you never know for sure which one is going to really pan out. But I think it's just overall very exciting that people are doing research on this disease, and very good research, very interesting research. So.
Thank you. Dr. Urrea-Mendoza, what are you most excited about?
Well, I totally agree with Dr. George in the sense that we are now living or experiencing a lot of research, right? Most of them only doing it in Parkinson's disease, but at the same time, you know that Parkinson's disease is quite similar in order to the pathophysiology with MSA, right? That's why some medication that we do research in Parkinson, well, can be applied in MSA. That's one thing. Many conditions and many medications in phase 1, phase 2, even phase 3, some of them that at some point can be applied as well in MSA. Good news. The second thing is, Dr. George mentioned as well in your excellent lecture this morning is all the biomarkers. We are doing a lot of research, improving the I would say affinity in order to be close to the diagnosis of MSA. And if we have that, okay, we have early onset of MSA, and with that we can try medication that maybe can be useful to decrease the progression, can be useful to treat some symptoms. I think we are living in a good time, and hopefully as well as a researchers and specialists at some point soon we can get that response.
Thanks so much. Dr. Tio, what are you most excited about?
That's the complicated question, because I totally agree with Dr. George and Dr. Enrique about the research going on, but I'm also excited with one other thing. That's the rise of patients' voice, because here in Uzbekistan and Russia, I'm facing the difficulty with providing sophisticated and positive information for patients, because most of them, I found them in a severely depressed state when they Google it, find in their native language old-fashioned information, and they become very severely depressed. And I spent quite a huge time managing their depression, informing them, educating them. And I'm deeply fascinated in the way that the alliance is now working on the spreading information, and people in each and every village, far from a city, with available internet, is now accessing the information and getting this piece of hope, because they are in the bubble of negative information. So you see, and I think that the most exciting thing now is that we are having the hope, and we are spreading the hope, and we are convicting people to fight against disease. And they see that they are not the unique ones, because I've seen so many patients who thought that their disease is unique, because they look around and nobody else was MSA in their village, in their small cities, and so on. But here we are now talking about this rare disease, and we are spreading this hope, and I think that's the most fascinating thing that's going around, of course, in addition to all researchers. And also,
thank you so much.
And this is something that crossed my mind when we were talking about planning for the future a little bit back, but it's something I try and remember to tell all patients I'd like to bring up, which is about falls and behavior medication. Whether you have cerebellar or Parkinson's, your balance is going to get bad. It's going to be worsened by any orthostatic hypotension. You've spent your life with good balance. You need to start developing habits that will keep you from winding up in the hospital as your balance gets worse. You want to always use a handrail going up and down stairs. If you have stairs in your home without a handrail, get one. Get grab bars in your shower, in your bathroom, because falls in the bathroom kill people. And when you put on your clothes, you sit down, put your feet in your pants or whatever, and stand up to pull it up, because otherwise, sooner or later, you're going to have a bad fall. And it takes a while to develop those things into habits, and you want to develop those as habits and have the railings and so forth there before you actually need them. So just wanted to get that in there.
Thank you so much. We have global hope. We have an entire world doing research and contributing knowledge toward a cure. And then there's also the empowered way that patients can make this disease as manageable as possible for them on a day-to-day basis. I think that's a wonderful message. Thank you so much to the three of you for being here. I can't tell you enough how helpful this is for our audience to hear, and we're so grateful for your time, even on a weekend. A little plug for the sessions that Defeat MSA will be hosting tomorrow, same time, same place. So starting at 10 a.m. Eastern time here in the US, there will be a series of lectures including an Ask the Scientist session that happens at 11:45, so similar to this, where you can get all of your science and research questions answered. And please encourage you to communicate with the Defeat MSA board through the hub, how helpful these sessions are or how we can better moderate them or suit them to your needs, because we really are here for you. So with that, we'll close out for today. Thank you, thank you, thank you. And we will see you back here tomorrow.
Thank you, everyone.
Thank you.
Thank you. It's a real pleasure.
Thank you. Bye-bye.
Bye.